Bismillahirrahmanirrahim. Assalamualaikum everyone. I hope every one of you is doing really well. Well, the topic for today is purgatives and laxatives. With this topic, you're going to start off with your gastrointestinal pharmacology. This is your first lecture on GI pharmacology. This term, laxatives and purgatives, I hope is not a new term for you, and you are already familiar with this term, and you're already familiar with the fact that these drugs are used in a very common complaint of constipation. And also, you might know that this group of drug is a very commonly prescribed drug and is also self-prescribed by a large number of people, and is very easily available over the counter. So to begin uh, formally, let's just have a look at the learning objectives. So if you keep listening attentively, by the end of this lecture, you will be able to define and understand constipation. You will be able to relate lifestyle modifications to the management of constipation. That is, you will be able to know the role of non-pharmacological options to manage constipation. Then you will be introduced to different groups or different drugs which are used in the management of constipation. And you know that these groups are called laxatives or purgatives. And we will be describing each of this group in detail regarding their mode of action, indications, adverse effects, and contraindications. And towards the end, we will be briefly discussing about the abuse of laxatives and the complications which are associated with this abuse. So let's move forward. Before formally getting into defining and understanding constipation and the drugs that are used in the management of this very common gastrointestinal symptom, let's first revise, or I would say review, the normal physiology of GI gut peristalsis. You might remember that gut peristalsis is basically a reflex response which is initiated when the gut wall is stretched by the contents of the lumen. And the contents of the lumen in this case we assume are the food bolus. So the peristalsis is actually a gut reflex and is defined as a series of symmetrical and alternating waves of contractions and relaxations. And they occur in such a way, they take place in such a way, or they propagate in such a way that they, they push the food bolus downwards into the gastrointestinal tube in an interrograde fashion. So this is what a normal peristalsis is, that it is a wave of alternating contractions and relaxations meant for pushing the food bolus downwards from the mouth towards the anus. This is something that you've already studied in greater detail in your physiology. And you know, whenever a food bolus reaches at any particular segment of the gastrointestinal tract, it always distends the gut wall, and this distension leads to the local peristaltic reflex, which comprises of contraction in the proximal segment and relaxation in the distal segment, so that the food bolus is pushed forward or pushed downwards, so as to say. And the chemical mediators involved in the proximal contraction are acetylcholine and substance P, and the mediators involved in the relaxation of the distal segment are ATP, nitric oxide, and vasoactive intestinal peptides. So this is how this wave of peristalsis continues to propagate and pushes the food downwards from the anus, from the mouth towards the anus. Now, this is something that you've already studied in a lot of detail in your previous classes. And another figure showing you, enabling you to revise the normal peristaltic activity. Okay, now let's move forward. Now that you have revised the pharmacology, or you have recalled the normal gut peristaltic wave activity, now just review, or let's just talk in some detail about what happens in the gastrointestinal tract, what mediators are released, what are the neurotransmitters, from where they are released, which different types of nerve afferents or efferents are involved, what are the different nerve systems that are involved, what are the different nervous systems that control the whole of this peristaltic activity. So we'll be talking about all of this in some detail. So please concentrate on this figure. This is from your caption. And this is very important to understand over here, because once you have understood this whole concept well, then you will be able to conceptualize the normal peristaltic activity and the drugs which can stimulate this peristaltic activity and can then eventually manage the symptom of constipation. So before we get into the pharmacology and the drugs and the site of actions and the mode of actions, we have to review the normal neurophysiology of this peristaltic activity. Now, what happens? Once the food bolus enters at any particular segment of your gut lumen, it distends the gastrointestinal wall. Of course, you can see that pressure is exerted onto the enterochromaffin cells. These are the EC cells or enterochromaffin cells in the GI mucosa, and they are responsible for the release of a large chunk of serotonin. And you might remember from your previous knowledge, this is 5-HT serotonin, you might remember from your previous knowledge that 90% of the serotonin is localized in the GI tract. And again, you might remember or you might be able to recall that serotonin has a large number of receptors. It has a large family of receptors. Around 14 subtypes or 14 receptors have so far been located. And many of them are also located in the GI tract. And you can locate some of the serotonin receptors over here in this figure. Like you can locate 5-HT3 receptor, you can locate 5-HT1P receptor, then you can locate 5-HT4 receptor. Sorry, I have to go back, yes. Now, what happens when the pressure is exerted onto the enterochromaffin cells? Serotonin is released. This serotonin is going to stimulate 5-HT3 receptors, and this impulse is then going to be carried to the central nervous system. So this particular nerve afferent or afferent nerve, which is going to carry the nerve impulse to the central nervous system, is labeled as extrinsic primary afferent nerve. Okay, so this nerve is labeled as EPAN or extrinsic primary afferent nerve. On the other hand, towards the right in this figure, we have IPAN, which is intrinsic primary afferent nerve. What's the difference? This extrinsic primary afferent nerve is going to take this impulse to the central nervous system and is going to receive input from there. But on the other hand, the IPAN is going to receive input from the enteric nervous system neurons and is going to be regulated locally. So again, from your previous knowledge, you might be able to recall that the gastrointestinal tract has its own nervous system, which is called the enteric nervous system, which is also called the gut brain, and it is independent in its action and is autonomic, it is automatic, and it regulates a large number of localized gut reflexes. So over here, we can see that the simple pressure exerted by a food bolus can stimulate the release of serotonin from the enterochromaffin cells and can stimulate both the extrinsic as well as the intrinsic primary afferent nerve fibers. Right now, we're not concerned with the extrinsic primary afferent nerves and the 5-HT3 receptors. We will be talking about 5-HT3 receptors and the extrinsic primary afferent nerves, extrinsic primary afferents, once we will discuss antiemetics with you. But currently, you just focus on the intrinsic primary afferent nerves and these receptors, the 5-HT4 and 5-HT1 receptors. Now, once the serotonin is released and it stimulates the 5-HT1P receptors, it eventually causes the release of acetylcholine and calcitonin gene-related peptide over here, presynaptically. And this acetylcholine would be eventually responsible for the contraction of smooth muscles and eventually would initiate the contraction in the proximal gut segment, the proximal segment, which is actually proximal to the food bolus. So quickly revising this, the food bolus is going to enter this particular segment. It is going to push the enterochromaffin cells to release serotonin, and serotonin via 5-HT1 receptors would cause the release of acetylcholine and CGRP, and this acetylcholine and CGRP would eventually cause contractions in the smooth muscles of the gastrointestinal tract. And once the smooth muscles are contracted, of course, there's going to be contraction and contraction in the proximal segment. Now, let's move forward. Again, in that previous figure, we talked about the release of acetylcholine and substance P, which was responsible for the contraction of circular smooth muscles. And while there was contraction in the circular smooth muscles, at the same time, there was relaxation in the longitudinal muscles of the gastrointestinal tract, and it was mediated by the release of inhibitory neurotransmitters, that is nitric oxide and vasoactive intestinal VIPs, vasoactive intestinal peptides. So contraction of circular smooth muscles and relaxation of longitudinal muscles will cause the contraction of the proximal segment. And at the same time, there would be the exact opposite effect onto the segment, which is distal to the food bolus. And over here, there would be inhibitory neurotransmitters released for the circular smooth muscles, and excitatory neurotransmitters would be released for the longitudinal smooth muscles. And eventually the result would be relaxation of these muscles in the segment distal to the food bolus. So this is how the whole peristaltic activity is brought about. Proximal segment contracts because of acetylcholine and substance P, and the distal segment relaxes because of nitric oxide and vasoactive intestinal peptide. So from here, we can assume that drugs which can modulate the levels of acetylcholine, drugs which can modulate the levels of serotonin can have some role in managing constipation. So let's see how our assumptions are verified. We'll now move forward. Now that we have understood the basic physiology and the neurophysiology of the peristaltic activity, now here this is another figure, or just that this figure is just highlighting the important neurotransmitters and important mediators which have an important role to play in peristaltic reflex. We have already discussed the role of acetylcholine and serotonin, and we'll be mainly concerned with only these two mediators. But please make note that enkephalin, which is the naturally occurring neuropeptide, also has a role in peristaltic activity. And you might remember that whenever a person takes an overdose of morphine-like painkillers, he may develop constipation, or there is a high risk of developing constipation in such patients. So that means that enkephalin and endorphins and morphine-like painkillers also have some effect on gut peristaltic reflex, and there are mu and kappa receptors in the gastrointestinal tract. So far, just summing it up, we have learned that the normal peristaltic activity is regulated by acetylcholine and serotonin, and some other important mediators, important endogenous neuropeptides like enkephalins also have an important role in regulating the normal gut peristaltic activity. Now that's you have we have covered the normal physiology and normal neurophysiology of peristaltic activity. We'll be formally starting off with the subject matter, which is defining constipation, understanding constipation, and learning the drugs which can manage this problem. So constipation, as you know, is a phenomenon that has perceived differently by different individuals. So everyone is going to have his own definition of constipation. Some people would define it in terms of frequency. Some would define it in terms of the the volume or the consistency of the stools, and some would just simply say that they have a sense of incomplete evacuation. But medically, you should be able to define constipation, and you should know that it is defined as a stool frequency which is less than 3 times a week. So please know this, that the normal frequency of bowel movements in adults is about 3 times a day to 3 times per week, 3 times per week. So if it is less than 3 times a week, it can be labeled as constipation. So this particular symptom of constipation is often associated with other problems like abdominal pain, bloating, abdominal distension, and is often associated with a large number of complications like hemorrhoids, fissures, fecal impaction. So this needs to be addressed and this needs to be managed. Moving forward, what are the causes of constipation? Uh, by and large, the most generally, the patients who would come to you, they would have causes leading to constipation, which are related to their lifestyle. For example, they would not be taking enough fluid, they would not be taking enough dietary fibers, or they would have irregular bowel habits due to stressful working environment or stress that is related to their studies. Sometimes certain drugs can induce constipation, and you should be able to recall those drugs which have constipation as their adverse effect. Then again, pregnancy is often associated with constipation because of excessive levels of progesterone in the blood. Again, elderly patients because of the sluggish bowel, and in certain cases because of diabetes, they also remain constipated. And in certain cases, the causes are definite anatomical and physiological causes, like painful anal lesions can be the cause. And idiopathic causes. Idiopathic constipation is also called functional constipation, because in these individuals you cannot identify any single cause of constipation, yet it is there chronically, and most often in these individuals the causes are psychological. Although there are no certain types of constipation, but we might like to just classify them into two broad groups. That constipation could be because either the bowel is spastic or the bowel is atonic. If the bowel is spastic, it means that it is suffering from spontaneous contractions or spasms. So if the bowel or the colon is suffering from spasms, the natural result would be constipation. And on the other hand, if the bowel is sluggish or slow, again, the result would be constipation. Um, Sorry. Management of constipation, again, one of our learning objective was to manage constipation non-pharmacologically. So please make note that most of the causes of constipation can be managed by simple lifestyle changes as mentioned here in this slide. But if patient does not respond to this or has no underlying pathology, and then he might need um, uh, to be he might need to be given laxative treatment. Otherwise, always prefer or always go with lifestyle changes first. Now, having understood this disease and the causes, now let's talk about the drugs that we can prescribe a patient to a patient of constipation. The drugs are called laxatives, but there are other words that are used for this group of drugs. They're also called evacuants, they're also called purgatives, they're also called cathartics. Now, although these words are used synonymously, but there are important differences amongst these terms. For example, laxatives are the drugs from this group which have a milder action, which have a slower onset, and are used for chronic constipation. Um, their use would make the passage of stool easier, but the stools formed would be properly formed. The resultant stools would be properly formed stools. On the other hand, when we talk of this group cathartics, they have a more intense action, and they are just going to increase the urgency of passing stool, and as a result, the stool that would be formed will be probably of liquid in nature or will have a semi-formed consistency. And the third category is of purgatives, which would be having the most intense action out of all these. Out of all these, and once the action is so intense, this is going to cause the whole of the gut contents to be evacuated within just minutes or hours. So laxatives are having a milder action and a use for chronic constipation, whereas cathartics and purgatives have more intense action and are often used when an intense evacuation or when a sudden evacuation of gut contents is needed, like for example, prior to surgery or prior to endoscopies. So this is, I hope this difference between laxatives, purgatives, and cathartics is clear. Now, moving on to the classification. Please, while I will be pronouncing these drug names loud and out for you, and I would I would suggest that you also repeat these names with me so that they're easy for you to learn and pronounce. So they are basically 7 groups of the drugs which are used for constipation. First group is of bulk laxatives. Second is of stool softeners. Bulk laxatives further has 2 types, the natural products and the synthetic fibers. Amongst the natural, we have bran, the dietary fiber, the isparol husk, which is psyllium, and methyl cellulose. In synthetic fibers, we have polycarbophyll. Amongst the stool softeners, or the surfactant agents as we call them, we have docusate, mineral oils like liquid paraffin, and glycerine suppositories. The third group is of stimulant purgatives. Again, it has 3 chemical subgroups, phenolphthalein and Bisacodyl are diphenylmethanes, and senna, cascara, and aloe vera, as in aloe vera, are anthraquinones, and castor oil is a fixed oil. Then we have osmotic purgatives as the fourth group, and they have lactulose and saline purgatives as their main constituents. Saline purgatives are further divided into 3 categories: the magnesium salts, the sodium salts, and the balanced polyethylene glycol. The fifth group is of serotonin 5-HT4 receptor agonists, and you might recall from the figure that I have just shown you in the beginning of the lecture that I told you that that receptor 5-HT4 receptor was a crucial receptor when we talk of management of constipation. So 5-HT4 receptor agonist like Digacerod, and I hope this name is not new, but you have heard of this name or this drug when you studied serotonin. Then at number 6, we have chloride channel activators, and lubiprostone is an important drug. That is why it's mentioned here. And at number 7, we have opioid receptor antagonists. Again, the flowchart that I have shown you in the beginning of the lecture also depicted that opioids have an important role in the development of constipation. So if those opioid receptors are blocked, or if you use opioid antagonist, the resultant natural consequence would be management of constipation. So the important drugs in this group are methyl naltrexone and elvimopam. So now that you have had a little bit of familiarity with these drugs, that there are 7 groups of laxatives, and you have now been told about their names. So that was just one way of classifying them. You can also classify them on the basis of the site of action, and you can have a look at this slide too. Some examiners do like to uh, ask about laxatives according to the site of action. So hence this slide is there for you. Now moving on to the detail of all these groups, the 7 groups, starting off with the first group, which is the bulk forming laxatives, and the names have already been mentioned and already been described. Now let's move on. Now, as the name indicates, that this group is the bulk forming laxatives. That means that it is going to form a bulk. Please keep that figure and that normal neurophysiology of gut peristalsis in your mind always. All the bulk forming laxatives like psyllium or isparol husk are actually hydrophilic colloids. That means they're water-loving colloids. So what will they do? They will attract water or they will retain water. And once they retain water, naturally the size would grow. And once their size is greater, they are naturally going to exert more pressure. So if there is going to be more pressure, there is going to be more stimulation of those neurons. And when there are more neurons would be stimulated in the myenteric plexus, and when there will be more neurons being stimulated, there would be more peristaltic activity. So this mode of action is quite easy and understandable, but the important thing to remember about bulk forming laxatives is that they cannot be used in acute constipation because they generally take some time to work. But they are often self-prescribed by many individuals because they have no serious side effects. So this is what the mode of action is, that they attract water and that eventually cause distension and stimulation of the peristalsis. So this is something that we have already discussed. So the bulk forming laxatives and other laxatives also have many indications in common. For example, most of the laxatives are used because the clinicians, they don't want constipation to develop after colostomies and ileostomies. Again, ulcerative colitis, maybe constipation prevent clinically, we can use them. Hemorrhoids and anal fissures are really painful anal pathologies, and in these particular conditions also laxatives are very, very widely prescribed. And irritable bowel syndrome has diarrhea alternating with constipation. In those individuals where constipation is a prominent symptom, often laxatives are prescribed. Now you have covered the first group. Now let's move on to the second group. The first group was of bulk forming laxatives. The second group is of fecal softeners, or you can also call them as fecal surfactant agents. Now, why surfactants? Because they have surfactant properties. And once they have surfactant properties, the common examples like docusate, and mineral oils, what they do is, because of their surfactant properties, they would permit water and lipids to penetrate into the lumen, to penetrate into the gut contents. And once the water and lipids get into the gut content, naturally there would be more distension and more peristalsis. Another thing that they do, other than that, other than the surfactant properties, is that they also retard the water absorption from the stool. So they have a dual mechanism. Sorry about this. So they have a dual mechanism. One, because of their surfactant properties, they permit water and lipids to penetrate, and they also retard the water absorption from the stools. So both these mode of actions contribute towards greater distension and greater peristalsis. Please keep this thing in mind that mineral oils like paraffins should be taken very cautiously in an upright position because they have a high propensity to cause aspiration and eventually pneumonia. Now, what is this? What is special about these fecal softeners is that they are often they're not routinely prescribed. They are prescribed in certain conditions only, like in children and in age extremities where there's a risk of fecal infection. They are prescribed, or they're prescribing in those individuals where there's a risk of worsening of a disease due to straining. So they are not routinely prescribed, as was the case with bulk forming laxatives. Stool softeners, however, have only certain specific indications. Why? Because they have side effects. And what are those side effects? If you keep on taking mineral oil, as I've already told you, they cause the water and lipids to penetrate. And once the lipid has penetrated into the stool content, the lipids are going to be lost from your body. So eventually, if you keep on taking this group of laxatives for a long term, you will be depleted with your fat soluble vitamin stores. So it is important that these drugs should only be taken for specific indications, and these drugs should only be taken once they are prescribed by a physician and not by self prescription. Now we have discussed two of the groups, the bulk forming laxatives and fecal stool softeners. So I hope you can answer this one. The non-digestible, non-absorbable agents which swell with water to form a viscous solution is bulk forming laxatives, and the group which has surfactant properties and lower surface tension, allows penetration of water lipids, is stool softeners. So this is the main difference. One is a hydrophilic colloid and the other has surfactant properties, but the net result is increased or enhanced peristalsis in both the cases. Now moving on to the third group, this is osmotic purgatives. You might notice that I have used this word purgatives with them. Already told you that purgative is a term which should be used for those drugs which are more intense in action and have more sudden onset of action and can cause the whole of the gut contents to be evacuated in little time. So because osmotic purgatives have this ability, this group has this ability, that is why we have used this term purgative with them. So what do they do? You might remember that osmotic purgatives were actually divided into two groups for the subgroups. One was lactulose and the other was saline purgatives. In both these cases, you whether you give lactulose or whether you give saline, the mode of action is same. That is, this lactulose is actually an unabsorbable sugar, and the saline purgatives are unabsorbable salts. Whether sugar or salt, in both the cases, they are osmotically active and they can exert osmotic pressure, and they can then cause an increase in the fluid content of the stool. So as you know, that colon has this ability to not absorb, or it does not change the water content of the fecal matter. So once an osmotic laxative is taken, it is going to stay there with the gut contents, and it is going to remain unabsorbed, and it is going to exert an osmotic pressure, which is going to cause an obligate increase in the fluid volume. So whether it's lactulose or saline purgatives, the mode of action or the mechanism of action is same. We'll be talking in detail about lactulose. You might be familiar with this drug by the name of Duphalac, a very commonly a kind of household drug, uh, is found in almost every house, and is widely taken for constipation. Again, one of the drugs which is very much self-prescribed. So lactulose or Duphalac is basically an osmotic laxative, and it has a non-digestible disaccharide, that is, it is a sugar, and as the mode of action has already been discussed, that it osmotically drives water into the lumen and would initiate the propulsive activity or the peristaltic activity. An important thing about lactulose is, which is again an important viva question, that it is not only used in constipation, but it is also used for hepatic encephalopathy. How? We'll be talking about this in the next slide. For now, make note of the adverse effects. Then they're very common, commonly occurring adverse effects of flatulence and cramps and diarrhea with this lactulose. So the dose should be very much uh, cautiously taken and cautiously adjusted. Okay, so I've just told you that lactulose or Duphalac is used in hepatic encephalopathy. Now, what is the reason behind this? What is the rationale of using lactulose, which is an osmotic laxative, in hepatic encephalopathy? In the previous slide, you might have noticed that this lactulose is converted into lactic acid in the gastrointestinal tract, and which makes the gut lumen acidic. The acidic medium of the gut lumen, it promotes the conversion of uh, ammonia into ammonium. And please keep this in mind, that encephalopathy and chronic liver disease is caused by raising levels of serum ammonia. So you need to get rid of serum ammonia by any means. So one of the ways of getting rid of serum ammonia, of ammonia from the blood, is to convert into to get it converted into some other form which is not absorbable. So this drug, lactulose, what it does is that it enables or it promotes the conversion of serum ammonia or ammonia to ammonium, and that ammonium is easily lost in stool. So when resultantly there would be lesser amount of ammonia in the blood levels, and the encephalopathy would improve or would be treated. So hepatic encephalopathy, the dose is mentioned. It is generally taken in sufficient dose so that a patient of chronic liver disease passes stools two to four times a day to prevent the buildup of ammonia once again in his blood and to develop encephalopathy once again. So it is used to treat hepatic encephalopathy as well as is used for preventing hepatic encephalopathy in patients of chronic liver disease. Okay, saline purgatives, again, saline purgatives are also osmotic purgatives like lactulose, and again the mode of action is same, but remember the word purgatives is used for them. That means that they are going to cause rapid and prompt evacuation of bowel and bowel contents or gut contents within hours and not within days. So that is why, because of the intense action, these are also called purgatives. So what do you think? If something is having more intense action and is causing this excessive and intense and prompt bowel evacuation, naturally it is going to be indicated only for certain conditions, like treatment of acute constipation and like preparing the bowel for medical procedures like colonoscopies. And if it has the ability to evacuate gut within 1 to 3 hours, then naturally these saline purgatives can also have a large number of adverse effects like electrolyte imbalances. Lactulose, of course, can cause we have already discussed the adverse effects of lactulose, but just focus on the adverse effects of saline purgatives. They can cause electrolyte imbalance like hyperphosphatemia, hypocalcemia, hypernatremia. Although in normal patients, they are not worrisome, but they should be taken care of when you prescribe such drugs, such saline purgatives to cardiac patients and to renal patients. Okay, so again, the caution is that these saline purgatives and these osmotic purgatives should be very cautiously prescribed to renal and cardiac patients. Okay, the third component of saline of osmotic purgatives is balanced polyethylene glycol. Okay, the mode of action once again would be the same, that it is going to exert osmotic pressure. It contains an osmotically active non-absorbable sugar, just like lactulose and just like other saline purgatives. The mode of action is same, but because it is composed or it is constituted in such a way that it turns out to be a balanced isotonic solution, and hence it would have no adverse effects or it would have minimum adverse effects. And it is designed to prevent that the depletion of intravascular fluid and depletion of electrolytes or electrolyte imbalances would not be caused by the use of balanced polyethylene glycol. And this balanced polyethylene glycol is again used only for certain conditions, like again gut preparation before surgeries or before endoscopies. It is taken orally. It is generally in a powdered form, and it is dissolved in water, and it is 1 to 2 liters of that balanced polyethylene glycol containing water is taken by the patient night before the surgery or night before the endoscopy, and the gut is absolutely cleared of all its contents. So far you have studied three groups: bulk forming laxatives, stool softeners or surfactants, and osmotic laxatives. And in osmotic laxatives, you talked about three things: saline purgatives, lactulose, and balanced polyethylene glycol. Now, moving on to the fourth group, it is the irritant purgative. Please make note that this is an important Viva question, an important university question, the mode of action of stimulant purgatives, but it is not very well mentioned in your textbooks. So you will have to go through, you will have to study the mode of action of this particular group from the lecture. Summarizing the mode of action of this particular group, the stimulant or the irritant purgatives, is that again, it is a purgative. It is going to have a more intense action. And what this group does is that it directly stimulates the enteric nervous system. It directly stimulates the myenteric plexus. And when the myenteric plexus is stimulated, there is going to be smooth muscle contraction and there is going to be initiation of peristaltic activity. The other thing that this group does is that it can also cause increased fluid secretion and increased electrolyte secretion like chlorides. So both these mode of actions would cause rapid propulsion of intestinal content. So this is the mode of action, but we'll be talking about it in further detail in the slides to come. This group of stimulant laxatives again is not indicated for all the patients. It again has some specific conditions, specific indications. Um, Although it is not very safe, but again, it's because it is very efficacious, so it is used in some conditions for long-term basis, like in patients who are neurologically impaired or in bedbound patients, they are used for long-term basis as well. Now we'll be talking about these saline purgatives in further detail. The side effects, again, I'll be talking about these once we have discussed the mode of action. So you might remember from the slides of classification that saline, these stimulant laxatives are further divided into three categories: anthraquinone purgatives, then there is this Bisacodyl, and then there is castor oil. When we talk anthraquinone purgatives, they are characterized by aloe, senna, and cascara, which are naturally occurring derivatives of plants, and they're very effective. Once you take them orally, they can cause they can initiate this defecation process within 6 to 12 hours, but they are more prompt in action when given rectally. Now, talking of the mode of action, the important thing, what they do, the aloe, the senna, and the cascara, which are the stimulant laxatives, what they do is that they are actually, I've already told you that they are derived from plants. Once they reach the colon in an unchanged form, over here, the bacteria in the colon, it hydrolyzes them. And when it hydrolyzes them, the free anthracene derivatives are released. It is these free anthracene derivatives of aloe, senna, and cascara which are going to directly stimulate myenteric plexus. And once the myenteric plexus is stimulated, there's going to be increased smooth muscle activity and increased peristalsis. So this is the mode of action of stimulant laxatives. Again, once when we give a drug of such intense action and with direct action on the myenteric plexus, naturally it is going to have more severe adverse effects like gripping during defecation. And an important adverse effect, which is often asked in the viva, is melanosis coli. What is this and how is this caused? The chronic use of stimulant laxatives, it has this ability to damage the GI mucosal cells. Chronic use of the stimulant laxatives can damage the mucosal cells, and once the mucosal cells are damaged, naturally they will undergo apoptosis and they will be taken up by the macrophages. So all this activity in the GI mucosa, because of the chronic use of stimulant laxatives, would give a blackened or darkened appearance to the gastrointestinal mucosa, and this would be visible uh, upon gross examination, like when you are doing performing an endoscopic procedure on such person's gut, but they are also seen under the microscope. So this melanosis coli is actually the darkened coloration, the dark or the blackening of the GI mucosa because of excessive use of or chronic use of stimulant laxatives. And it is very much seen, although it has no sign and symptoms, But and another important thing, another good thing about this adverse effect is that it goes on, it goes away once you stop taking the stimulant laxatives. Okay, now moving on to the second group of stimulant laxatives, we have Bisacodyl. Bisacodyl is again a stimulant laxative and can also be, because it is a purgative, it is going to have a more severe and more intense section, and that it will be used for acute as well as chronic constipation. Often this Bisacodyl is often combined with balanced polyethylene glycol solution prior to endoscopic procedures like colonoscopy. And again, this, although it is a stimulant laxative, but overall, because of its minimum systemic absorption, it is very much safe for long-term use. So this is an important uh, laxative or important purgative from clinical point of view. Now, the third one is castor oil. Again, it is third in the group of stimulant laxatives. It is again a very potent stimulant laxative, and some examiners like to ask its mode of action, which is a bit complex. That is not very much used, but please go through its mode of action once at least. This castor oil is converted into this ricinoleic acid in the large intestine, in the small intestine, it is converted into ricinoleic acid. And this ricinoleic acid, which is released from the castor oil, is the chief ingredient. And this ricinoleic acid is going to stimulate or irritate the gastrointestinal tract. And by that irritation, it is going to initiate the peristaltic activity. Now, in further detail, if you want to have a look at the further detailing of its mode of action, the ricinoleic acid, which is the main active ingredient, it is going to have an agonistic effect on EP3 and EP4 receptors. So these are the receptors for the endogenous prostaglandins. And please, you might remember that prostaglandins have a stimulatory effect on the gastrointestinal tract. The prostaglandins can enhance the secretion, the electrolyte secretion and fluid secretion in the gastrointestinal tract. So because this ricinoleic acid is stimulating the prostaglandin receptors EP3 and 4, this ricinoleic acid is also going to cause an increase in the fluid and electrolyte secretion in the gastrointestinal tract. And the other thing that this ricinoleic acid does is that it can also directly stimulate the enteric nervous system. It can directly stimulate the enteric plexus and is going to cause and can cause peristaltic activity. So the stimulant effects of the stimulant laxatives is mainly because of their direct effect on the enteric plexus. And once the enteric plexus is directly stimulated, there would be enhanced peristalsis. And one of the stimulant laxative, the castor oil, also has direct agonistic effects on the prostaglandin receptors. And whenever the prostaglandin receptors in the GI tract are stimulated, there is increased fluid and electrolyte secretion of the gastrointestinal tract. So this is the mode of action of the stimulant and irritant laxatives, which is not mentioned in your textbooks. Okay. Fifth group, finally, chloride secretion activators. Again, from your previous knowledge, you might remember that whenever there is increase in the chloride secretion in the gut, it always has a stimulatory effect on the peristaltic activity. Whenever the chloride, the intestinal fluid is rich in chloride, that increases the polyperistaltic activity and it decreases the intestinal transit time. So this is the basic principle or the basic mode of action of chloride secretion activators. Like, for example, lubiprostone. So what is this drug doing? This is directly having an effect, or it is directly opening some chloride channels in the small intestine. So its mode of action is in the small intestine. And as a result of this, it is going to increase chloride. It is going to increase the content of chloride in the secretions and would cause the stimulation of motility. So the mode of action is simple, but it is not used for all types of constipations. It is mainly and primarily used for chronic constipations only. And from chronic constipation, it is preferably used in irritable bowel syndrome. Okay. A Apart from this lubiprostone, there is another group of drugs it is not going to have direct effect on the chloride channels. Rather, it is going to have any these drugs are going to have effects on the cystic fibrosis transmembrane conductance regulator, the CFTR, which is actually a chloride channel. So lubiprostone we just discussed, and now we are discussing linaclotide and plecanatide. Linaclotide and plecanatide are two other chloride secretion activators, which are also going to cause an increase in the chloride secretion in the gastrointestinal contents, but not by stimulating the chloride channels as we have previously discussed. Rather, they are going to activate this enzyme guanylyl cyclase, which would eventually activate the cystic fibrosis, the CFTR regulator, which is, and the CFTR make, I hope you know that it is a chloride channel. So this linaclotide and plecanatide is indirectly stimulating another type of chloride channel, which is CFTR. Okay. Again, these two drugs like lubiprostone are also used for chronic constipation and particularly for the irritable bowel syndrome with prominent constipation. Okay, now moving on to the sixth group, which is serotonin receptor agonist. Please, I hope you remember this figure or the discussion that we had initially when we started off with the lecture. And I told you to please keep this thing in mind that 5-HT4 receptors are important receptors when we talk of constipation and mismanagement. So this drug, this tigacerod, is this drug which is going to have an agonistic effect on these receptors. And once these receptors are stimulated, the natural result would be the release of acetylcholine. And again, you might remember that when acetylcholine is released, it leads to smooth muscle contractions in the segment which is proximal to the food bolus. So their mode of action is very much understandable. Again, stimulation of 5-HT4 receptors, and they cause the proximal bowel contraction via the release of acetylcholine and substance P, and would eventually promote peristaltic reflex. But apart from this mode of action, they have another mode of action, which is that of increasing the chloride secretion in colon. So they have basically two mode of actions. And this can be very much easily explained if you have that particular diagram in your mind, or where the 5-HT4 receptor and the release of serotonin is depicted. Okay. This again is not used for all type of constipation. It is generally used for chronic constipation, and for example, like the chronic constipation which is seen in gastroparesis and irritable bowel syndrome. Okay, the adverse effects, generally it is considered to be a very safe drug, but sometimes diarrhea may occur with this drug. But and contraindications of most of the serotonergic drugs are that they should not be advised to patients suffering from hepatic and renal impairment. Okay, finally we have reached the last group of laxatives, which is the opioid receptor antagonist. So far, um, when we were discussing the normal mediators that are involved in regulating the peristaltic reflex, we talked about the role of opioids and the role of enkephalins and endorphins in causing constipation. So if they cause constipation, so anything that is going to block or is going to have an antagonistic effect on the neoreceptors or the opioid receptors would naturally treat constipation. So opioid-induced constipation is a very common problem. Patients who have been taking opioids for a long term eventually suffer from this adverse effect of constipation. And even in those patients who have recently had a surgery, and because of the surgery, they were advised opioids for pain relief, they also suffer from paralytic ileus. So all this particular form of constipation is mediated through intestinal neoreceptors. The drugs in this group are methylniltrexone and alvimopam. So we'll be just briefly discussing them. Methyl naltrexone, the important thing about both these drugs is that both of them are not going to cross the blood-brain barrier, and they're not going to antagonize the pain relieving effect of opioids. They are just going to have the only peripheral impact or peripheral effect, and they are just going to antagonize the peripheral effects of opioids. And the peripheral effects over here were constipation. So they would antagonize constipation, the effect of constipation. Please make note that again, methyl naltrexone and alvimopam, which are the opioid receptor antagonists, are not used for all types of constipation. This methyl naltrexone is specifically used for opioid-induced constipation in those patients who have been using opioids for a long term because they are on because of some advanced illness. And please make note that this methyl naltrexone is used subcutaneously. On the other hand, the other drug, which is alvimopam, again does not cross the blood-brain barrier, and it is not going to antagonize the pain relieving effects of opioids, but it can definitely have an effect on the intestinal mucoreceptors, and as a result of which it is very much approved and very much used for the management of paralytic IBS in hospitalized patients. But please remember that this drug alvimopam cannot be used for more than 7 days because of the potential of cardiovascular toxicity. Okay, we have discussed all the 7 groups. I hope the mode of actions of all these 7 groups are very much clear. Now, just a very quick look at some other aspects of this topic. Enemas or suppositories, I hope you are aware of this mode of rectal drug administration. Enemas are again a very commonly and widely used technique, which is very much employed to treat constipation, for example, in gynecological and obstetric wards. Enemas are given. In this particular procedure, you don't need a particular drug group. Rather, you just need some fluid or normal saline to be instilled into the rectum, and that results in evacuation of the bowel within few minutes. And of course, the stool that is passed is very much unformed and is of liquid consistency. So the main principle of enemas and suppositories is that they make use of this initiation of the evacuation reflex, and resultantly they would be uh, evacuation of the gut contents. So throughout, we have been discussing the indications of various laxatives. They're used in functional constipation, for avoiding straining in bedridden patients, and we have missed certain indications while we were discussing the groups in detail. But those indications have been mentioned here, like in certain poisonings, you have to use some purgatives with more intense action, like saline purgatives. Again, this indication has already been discussed, and sometimes you have to administer these purgatives with antihelminthics so that the worm and the drug is easily flushed out. Contraindications, again, you will never prescribe these drugs to the patient who have a definite organic cause to constipation. In those patients, the cause must be addressed, the cause must be managed rather than just treating the constipation, which is just a symptom. We just quickly we talked about the drugs which cause constipation, and I asked you to please recall those drugs which cause constipation. So here there's this list of drugs which you have already covered, and all these drugs have constipation as a major adverse effect. So if any person is taking any of these drugs and is suffering from constipation, a physician might like to switch that drug. Okay. The abuse is very much prevalent, and we must make sure as physicians that patients do not self-prescribe these purgatives or laxatives because they have this ability of abuse. They have this potential of abuse, and once this habit is formed, it is not easy to break. So those patients who get into this purgative abuse must always be psychologically must have always have a psychological analysis. And again, if a person suffers from purgative abuse, he can have so many complications, like they could be a rupture of inflamed appendix, natural consequences of electrolyte imbalance, and if a person is taking purgatives continuously, he may suffer from malabsorption syndrome, protein losing enteropathies, and the spontaneous gut contractions um, may occur. Like he may develop spastic colitis. Okay, now this is the last slide. You would be guessing the preferred laxatives for the following indications, for each of the following indication, and this is also your assignment. I would also be posting this question separately in the assignment section, and please fill this up and send it back to me. Okay, thank you very much for your patient listening. I hope this was an easy topic, although lengthy, but good luck for studying. Good luck with studying. Okay.